It's May the 2nd, 2025. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor with RheumNow.com. May is Lupus Month. May is the month we're going to do a big lupus campaign. More on that later. Today, we'll talk about a new FDA approval and a diabetes drug that works in osteoarthritis, but it's not the one you think. But first, a message. Let's start with an FDA announcement. The FDA this week approved upadacitinib, or Rinvoq, for use in giant cell arteritis based on the data from the SELECT GCA study. We started talking about that a few meetings ago. A very successful study of patients getting either 15 milligrams or 7.5 milligrams 15 milligrams or placebo of upadacitinib or Rinvoq to treat patients with active giant cell arteritis, and 15 milligrams per day was shown to be highly effective. This is the 9th indication for upadacitinib, and it's now in the package insert. No new safety signals, no new precautions were advised. These patients were often being treated, as you would imagine, for giant cell arteritis with steroids and had a weaning or tapering regimen employed in those studies that was successful. Again, the question is, how are you going to fit this in? Will this be steroid-sparing therapy? This is a second drug that's been FDA approved for use in GCA, and I think this is a big advance, whether you use tocilizumab or whether you use upadacitinib. We have a lot of lupus reports this month because it is Lupus Month. We have a big lupus campaign. One such report comes from a study of African American children from the South who were compared to a multi-ethnic group. This is 45 patients with lupus, childhood lupus, who were African American. And it turns out that patients who were African American had significantly higher disease activity and greater damage over time. They started out with high SLIC scores of 8.4, SLEDAI scores of 13. With treatment and follow-up, the SLEDAI dropped from 13 to 7.4, at 6 months to 4.7, but that's still high at 1 year. So childhood lupus is bad, much worse than adult lupus. But then turns out that if you are African American, you're going to also do worse, and that's been shown in adult cohorts. And because this is a pediatric rheumatology lupus report, they put in there that the average distance that these kids were traveling for their room visits was 75 miles. There's a serious shortage of pediatric rheumatologists and care for kids with childhood lupus. I like this report about predictors of bacterial infection. A single center study of 116 juvenile SLE patients diagnosed with bacterial arthritis. That was seen actually in 17% of those 116 that had a bacterial infection. Looking at many, many different biomarkers, what best predicted bacterial infection, it turns out it was procalcitonin. You know, we talk about this as a measure. We don't do it very, very much. It's not widely used. It probably should be used. It was compared to the CBC. It was compared to sed rate and CRP, the neutrophil to lymphocyte ratio, the platelet to lymphocyte ratio, ferritin levels. While those other markers have value, their cutoffs are not determined. Were not determined by this study. By this study, it showed a procalcitonin level of greater than 0.9 nanograms per ml was predictive of those who would develop bacterial infection. I looked up the incidence of gout this week. As you know, gout incidence and prevalence has increased over time with the obesity epidemic, with dietary changes. At one point it was 8 million, then it was 9 million. The most recent report comes from N. Haynes 2017-2018, where the U.S. prevalence of gout is 12.1 million adults. That this is a significant increase from 2011-12, when the gout prevalence was 3.6 in the population, and this went up to 5.1% in 2017, 2018. The interesting thing about the most recent change in the last few NHANES evaluations was the doubling of the rate of gout amongst Asian Americans, going from 3.3 to 6.6%. That a sharp increase, and takes us up to 12 million people who have gout in our society. Another report about gout this week looked at what happens to gout after the emergency room visit. So 159 patients showing up with gout flares in the emergency department were studied and showed that only 35% of them had a follow-up outpatient visit after their emergency room visit. This is horrible. This is one of the big problems in gout management, is that the patients themselves are not good at follow-up. We're not good at ensuring their follow-up, and follow-up obviously means better care over time, less use of the emergency room, better prevention, and that's one of the problems. Those who are less likely to, or actually more likely to show up in follow-up, were those who were married, those who had no comorbidities, those who were on colchicine, those who were older. I guess being married, being wiser, being on therapy made the patient's management of their own gout a little bit more responsible and adult-like, maybe. I always like to put up the data about the risk of cancer with the drugs we use in RA patients or other inflammatory arthritis. This was looked at in the DanBio Register, a Danish registry, as you know, does fabulous work. They had 720 RA patients who had a prior solid cancer. These included breast, colon, bladder, melanoma, lung, endometrial cancers. And they were in remission from their cancer, but then went on to receive a biologic, either TNF or actually a number of different biologics. And they found out specifically that TNF inhibitor use or rituximab use had no increased risk of cancer recurrence. The same was seen with the other biologics that were under study. Specifically, patients who had breast cancer had no breast cancer recurrence that was increased over the controls. So again, this goes along with what we've said. Patients with solid tumors who have cancer should be treated as if they didn't have a solid tumor when it comes to their RA or biologic therapy. Use whatever you want. There's not one that's preferred. There's not one that's better. There's not one that's worse. Treat them as you should. Another study about RA and RA-ILD looked at the association with ANCA antibodies. We've talked about this before. A study of 104 RA-ILD patients found that 32% of them had ANCA-positive autoantibodies. 29 of those were, in fact, P-ANCA positive, not C-ANCA. And when compared to the RA-ILD patients who were ANCA negative, the ANCA positive RA-ILDs, not so good. Worse disease, more pulmonary symptoms, more ANA positivity, worse PFTs, more exacerbations, more bronchiectasis, worse honeycombing on CT of the chest. ANCA in RA-ILD, usually P-ANCA, which would be myeloperoxidase, probably a poor prognostic finding, right? There is that evidence about these RA-ILD patients where you should be doing KL6 as a biomarker to see where those patients are. That wasn't studied here, but I want to remind you of that other biomarker that's also new and out there, new to us rheumatologists at least. Immune checkpoint inhibitors are used. They cause autoimmune syndromes, we call immune-related adverse events, or IRAE. There's now reports of IRAE with the resultant manifestation being myasthenia gravis. The interesting thing about this particular report of 16 patients on immune checkpoint inhibitors who developed myasthenia gravis, and they were from mostly lung, and like more than 9 of those 16 were from lung tumors, that the patients who had myasthenia gravis, 11 of the 16 also had overlap myositis, and that These occurred roughly a month to two after the onset of therapy. All were given steroids. Most were given immunosuppressives or plasma exchange. The problem is that the outcomes were bad. Only two responded to the therapies given. 6 of the 16 died, and the others didn't do very well. And the ones who died of myasthenia complications, not of cancer complications. Kind of a bad manifestation of IRAE, don't you think? Pregnancies in the news, the Norwegian pregnancy data set called RevNatus, a study of 417 births and 350 women with axial spondyloarthritis, looked at breastfeeding. Good news, 86% of them at the time of delivery were breastfeeding out to 6 weeks, but that went down 70% by 6 months, 38% at 12 months. That's kind of normal. But compared to when they compared those who didn't go on breastfeeding, there were differences. The non-breastfeeders had more C-sections, double the rate of C-sections, higher ASDAS CRP levels of 2.6 versus 2.2 in the breastfeeders, higher CRP levels, more pain. Maybe the interpretation here is that AS patients, ex-SPA patients who are in pain, highly active, they're just not as likely to go on breastfeeding, and then I think that that the patient's going to suffer in many ways, but also the offspring is going to suffer. So again, I guess the point is make sure your patients are well controlled. There's no reason a patient with AxSpa can't be aggressively treated when they're pregnant with whatever drugs that you want to use. Again, if you don't have a healthy mother, you're not going to have a healthy baby. And I think we said that many times before. We put up some data this week about the cost of drugs that were incurred in 2024 in the United States, where pharmaceutical spending reached $806 billion in 2024. That's a 10% increase over that experienced in 2023. What were the most expensive drugs? I put up about 10 or 12 of the most expensive, led by the GLP-1 agonists, semaglutide and tirzepatide. Semaglutide, $54 billion spent in 2024. Tirzepatide, almost $32 billion. My goodness, that's $86 billion. We thought they were spending a lot in 2022, when Humira sales were at $22 billion. Well, don't worry, there's a lot of our drugs on the list too, and that would include adalimumab, now $28 billion, with a minority of that being due to brand name Humira, and the rest of it, I would guess around $9-10 billion. I don't know the exact number, but that's my guess, with the majority of that being biosimilar sales. So that's kind of good news, is it not? Other rheum drugs in the list, ustekinumab, $17 billion, risankizumab, $16 billion, etanercept still in the list at $10 billion, and secukinumab at $7.7 billion, upadacitinib at $7 billion. So we make the top 20 drugs, don't worry. Two big reports this week. I think the most important one came from JAMA about the efficacy of metformin in patients with osteoarthritis of the knee. So a study, it's a small study, and there's been reports before of metformin's use being advantageous in a lot of autoimmune situations. And it was sort of bystander use or co-therapy, and then looked at other outcomes, immune outcomes, inflammatory outcomes. In this study of 107 overweight or obese patients who did not have diabetes, by the way, they were randomized to receive either placebo or 2 grams a day of metformin. And it turns out that after 6 months, the metformin patients had a significant decrease in their knee pain scores by a 31-point change on a scale of 0 to 100, compared to placebo that only had a 19-point change, or 18.9. So the difference there is about 11.5 points, and that was significant. But the trialist had chosen 15 points as a clinically meaningful change in OA knee pain. So it did not achieve that, but everyone's kind of excited about it, including the authors saying this was significant results. Whether it's clinically meaningful, they had patients who had positive reports. So it looks like it was encouraging, and it's in line with what has been reported before. But again, this is a small study. They have shown that other studies that have shown that patients on metformin had less need for knee joint replacement and hip joint replacement, a 30% less need. And there are other examples where metformin may have a role. Now, why does it work? Is it simply lowering blood glucose levels has these effects? Or is it that there's another immune or anti-inflammatory effect? More studies are needed to know that. This month, we have a lot of planned content on lupus. We began with a great blog by Lisa Samaritano, who, as you know, led the ACR Reproductive Guidelines publication. Lisa's at Hospital for Special Surgery, wrote a really good blog about contraception in SLE that I would strongly recommend you read. Lupus patients who get pregnant have horrible outcomes. Lupus patients who get pregnant often were never on contraceptions of any sort. That contraceptive use is woefully deficient in lupus and could be used safely. She states in here that effective, long-acting, reversible contraceptives include IUDs, subdermal progestin implants. There are oral contraceptives, and those are very, very effective. There are oral contraceptives, both progestin only and mixed estrogen progestins, that can be used with almost the same degree of efficacy, and that they can be used even in patients with APS. The first two options, the implants and the IUDs, can certainly be used in patients with APS. So I think it's important for you to read that if you're managing young women with lupus, to get up to date on what the conversation is between you and your patients who have lupus and want to get pregnant or will become pregnant sometime in the future. I want to remind you that this month, May is Lupus Month. You'll see a lot of content from New Room Now about lupus. Our theme to our campaign this month, that is sponsored by Aurinia. Thank you, Aurinia. Our campaign is called Lupus Unlocked, the keys to mastery. And what we're going to present is basically giving you the keys to mastering lupus. We're going to have over 40 contributors, the best and brightest in the lupus world, who are going to be doing blogs, videos, webinars, journal clubs, podcasts, talking about contraception, pregnancy, cardiovascular risk, type 1 lupus, type 2 lupus. What's that all about? Steroid use, new rules on steroid use, mental health, psychosocial issues, immunologic aberrations in lupus, cutaneous SLE, pediatric SLE, the antiphospholipid syndrome, and a big effort covering lupus nephritis advances and also our need for renal biopsies. We're going to hear from nephrologists about their approach, how they manage CKD, even in the face of new lupus nephritis, GLP-1 and SGLT2 drugs and their benefits, biomarkers, CAR T-cell, more. Next Tuesday, this upcoming Tuesday, and every Tuesday this month, we're going to have a Tuesday night rheumatology webinar. We're going to lead off this first episode with the authors of the obinutuzumab in active lupus nephritis, the New England Journal article, I think it's called the Regency Report, and the voclosporin versus placebo, the Aurora 1 trial. Those papers were authored by their lead authors, Dr. Richard Fury and Dr. Brad Rovin, a rheumatologist and nephrologist, and they're going to take some questions from you, and we're going to send you some questions to ask them. So you want to be there. If you're a rheumatologist, you'll get an invite. You can attend the Zoom webinar on Tuesday night, 7 p.m. Eastern Time. That'll be 4 p.m. Pacific Time. And if you're not going to be on the Zoom webinar, you can watch it on YouTube, LinkedIn, Facebook, and also Twitter. We're going to post the recorded versions on our website and on those same social media channels. So be there for Journal Club this week. We hope you enjoy it. Tune in next week for more on lupus and great news in rheumatology. Take care. Wait, here's a message.